So good morning. We will talk about our last lecture, the hospitalized and terminally sick child. So after you listen to this video lecture and read also the slides, please answer the 15 question that is in the Google form that is also posted in this email. Okay. So it is very hard when a child dies, okay, or even just the fact that the child is sick. So pediatric death can be particularly challenging for both families and healthcare providers. That's why it's hard to be a pediatric nurse because you become emotionally involved. And we all know that a child upon birth can be subject to a lot of congenital conditions, anything that this harsh world can bring to the child, like cancer, accidents, and the other illnesses that we have discussed in this class. So, the emotional, social, and spiritual aspects of pediatric death really require sensitive handling. Death in children, this is a difficult concept for a child to understand, especially if the child is terminally ill, because you have to prepare also the child and comprehend what is going to happen next. And it is a bit difficult because the ability to comprehend it depends on their developmental stage. So let us also consider the family and the caregiver role. So families often experience intense grief. That's a given. Very hard to comprehend how much intense is their grief. They need support in decision making, caregiving, and generally ultimate coping with their child's death. So let us go through it following the developmental stages and understanding of death. So a child's understanding of death evolves with their age and their cognitive development. So their reaction to death will really depend on their developmental stage. So let us start with the infants, 0 to 1 year old. Well, definitely infants cannot understand the concept of death, but they can sense changes in their environment and caregivers' emotions. So the infant will be manifesting increased irritability, disrupted sleep patterns, and even changes in their feeding habits. For toddlers, that's between 1 to 3 years old, toddlers have limited understanding and may not even recognize death as something permanent. So some of the reactions could be regression. Regression meaning going back to previous behavior. So like bedwetting, thumb sucking, and they may be confused because of the changes in their environment. For preschoolers, that's your age 3 to 5 years old, preschooler understand death as temporary and believe in reversible magical thinking, meaning some magic can just bring the person back to life. So at this age, since there is already a beginning cognition, they could ask questions about death. They would show fear of separation. They can display guilt, thinking that they probably contributed to the death, to their not so good behavior. So there is a need to reassure this child. It is important to explain that death in a concrete and simple terms are permanent, and most important that they are reassured that they are not to blame for the loss of a person. For school age children, that is age 6 to 9 years old, these children understand that death is final, although they cannot fully grasp that it can happen to them or to the other people that they love. And so common reactions may become anxious, they become withdrawn, and even angry. Children would want to know why, seek information about death, and also have fear of their own death. Adolescents, that's 10 to 18 years old, They are now mature. They now see it as something permanent and inevitable. However, there are adolescents who could experience a wide range of emotions like anger, sadness, and confusion. They can also engage in risk taking behaviors to cope with the emotional pain. It is crucial to communicate openly and involve decision making about. So, according to Kubler-Ross, there are five stages of grief. So, this is best remembered with the initials DABDA. So, stage one is denial. This is the stage when the family may not accept the reality of a child's illness or impending death, followed by anger, where there is a feeling of injustice, blaming others, or simply being frustrated with the whole situation. And then bargaining begins. Family try to make deals with a higher power, God, or seek alternative treatments in hopes of prolonged life. And then depression. This is a deep sense of sadness and despair over the loss. Only then can the family or the person move to acceptance. Here, the family comes to terms with the reality of the situation and begin to prepare for the loss. Now, take note, these stages are not always experienced in a chronological order. Some of it may overlap, and some stages can extend longer than the other stages. Now, let us move on to how do we provide care for children who are at the end of life. So, number one concern is pain and symptom management. So, in general, children who are terminally ill may experience physical pain due to the illness or the treatments being done. So, appropriate analgesics would be like morphine, acetaminophen, and of course, we adjust it based on the child's age. Now, other symptoms such as nausea, difficulty breathing, fatigue will also be managed with medications and comfort measures. We need to learn as speech nurse this child-centered communication. We adjust our language and explanation based on the child's developmental level. Most importantly, we encourage the child to express their feelings, answer their questions honestly and clearly. For the parents, we provide counseling. We support the parents to help them cope with their child's illness and impending death. We encourage parents to stay involved in the child's care and especially in decision making. For spirituality, we respect the family's cultural and spiritual beliefs and we give them support, accommodate those beliefs, and help them find those needed resources. Now, we have this hospice and palliative care. When we say palliative, we focus on providing comfort, quality of life. This is not anymore about curing the illness. While hospice care is provided in a child's home, in a facility, basically to support the family as they prepare for the child's death. And there is involvement of multidisciplinary team. So the physicians, the nurses, the social workers, chaplains, counselors, all these members work together to provide this holistic care. Now, some ethical and legal considerations. So advance directives and also the DNR orders. So when we say advance directives, these are legal documents that outline the child or family's wishes regarding medical treatment. So whether they would want life prolonging interventions or not. So DNR orders means do not resuscitate. Some families may decide that resuscitation efforts should not be made in the event of child's death. And this is based on how they view the prognosis of the child. Now, decision making regarding life sustaining treatment should involve the parent and the healthcare provider. In some cases, older children and other members of the family may also participate in these discussions. So, as nurses, we could be in an ethical dilemma when we navigate challenges such as balancing child's quality of life versus parents' wishes. But in the end, it's always the child's best interest. Being a patient advocate, that is what we upheld. Now, the family going through the grief, there are phases of support. So one is before death. So we provide emotional support, information to the family, allow as much time that they could spend with their child, facilitate communication between the child, the family, and the healthcare team, and always encourage the parents to participate in the decision making because that will help them prepare for the emotional aspects of the death of the child. Now, after death, which is the post-mortem care, after the child dies, we provide respectful care of the body and allow the family to spend time with the child's body if they wish. We offer counseling services, support groups to help the family process their gift. And we do not end there. We give long term support. So we do follow up care as necessary for the family after the death. We provide referrals for grief, counseling, and support groups. And we acknowledge a family's grief on anniversaries and other significant dates, and we encourage them to honor their child's memory, especially if the child has been in long term care in the facility. Cultural sensitivity is also a concern. We have to be aware of the family's cultural beliefs surrounding the death because different cultures have different views on deaths, different rituals, different grieving process. Spiritually, we respect the family's needs. If they need to involve chaplain, facilitate prayer, or simply providing a quiet space for them to reflect and mourn. So, in terms of planning, okay, assessment, if we go through the nursing process, very basic, we assess the situation, the child's physical, emotional, and spiritual needs. We check the level of pain, the discomfort the child is going through, the family dynamics, how we can best provide support for the siblings and the parents. In the planning process, we collaborate with the healthcare team, and we develop a care plan to address the aspects physical, emotional, and spiritual need. I have added here a link that you can click so that you can see more care plans for future study. Nursing interventions would actually involve administration of medications, providing the support, opportunities, counseling, referrals. And of course, we evaluate our care as to how's the child's comfort, how's the family adjusting, if their needs are met, and how are they going through the grief process. So, death and dying, being ill is already anxious enough and depressing enough. So, this is a hard task for a nurse, and but it is something we deal with in pediatric care. No matter how young the child is, as the slide says, there is no food too small that it cannot leave an imprint on this world. Okay, that ends our discussion. That ends our PEDS lecture. And I wish you well in your next course or next undertaking in your nursing career. Thank you.